Hi everyone, welcome to our channel Canadian Nurse Expert. Today, we're diving deep into a crucial topic for nurses: increased intracranial pressure, or ICP. We're going to tackle 15 NCLEX style practice questions, and trust me, we're not just popping these answers out of thin air. We'll break down the rationale behind each one so you truly understand the behind the right answer. Whether you're a nursing student or a seasoned pro, this video is your chance to test your knowledge and gain valuable insights. Let's get started. Alright nurses, let's imagine you're caring for a patient with a traumatic brain injury. Their ICP is creeping up to 22 millimeters of mercury. You know that's a big red flag. Normal ICP is between 5 to 15 millimeters of mercury, so anything above 20 needs our attention. Now think of the brain like a delicate sponge. Too much pressure and it can't function properly. That's where our friend mannitol comes in. Mannitol is like a super strong diuretic. It works by pulling excess fluid from the brain tissue into the bloodstream, just like squeezing that sponge. This helps to reduce swelling and bring that ICP down to a safer level. So, what would you do? Administer IV mannitol? You bet. It's the right move in this situation. Okay, picture this. You're assessing your patient and you shine your pen light into their eyes. Uh-oh, their pupils are fixed and dilated. This is not good, people. It's a classic sign of brain herniation, a life-threatening condition where the brain is literally being squeezed out of the skull. Think of it like a balloon inflating too much inside a small box. Eventually, something's got to give. In this case, it's the brain tissue. We need to act fast. This situation calls for an emergent craniotomy. This procedure involves removing a portion of the skull to relieve the pressure on the brain. It's a big deal, but it can be life-saving in this scenario. Now, let's talk about a symptom that might seem a bit less dramatic but is still a major warning sign: nausea and vomiting. You might think, hey, lots of things cause an upset stomach. And you'd be right. But when it comes to increased ICP, projectile vomiting is a dead giveaway. Why? Because that pressure in the brain is putting the squeeze on the vomiting center in the brainstem. It's like someone's pushing that eject button in the brain. So if you're seeing this in a patient with suspected increased ICP, don't just reach for the anti-nausea meds. It's time to investigate further and address that underlying pressure. Okay, let's talk about blood flow in the brain. We know that too much pressure is bad, but so is too little blood flow. It's all about finding that balance. One way we can help regulate this is by managing our patient's PaCO2 levels. Think of PaCO2 as the traffic controller for blood vessels in the brain. When PaCO2 is high, those blood vessels dilate, letting more blood flow through. That might sound good, but remember, we're trying to reduce pressure. So, we want to keep that PaCO2 on the lower side. This causes the blood vessels to constrict, which actually helps to reduce blood flow and, you guessed it, lower that pesky ICP. Now, let's talk about ICP monitoring. When you have a patient with an ICP monitor, you might be tempted to flush the catheter, especially if you're used to doing it with other lines. But hold on a second. Flushing an ICP catheter is like shaking a bottle of champagne before opening it. You're just asking for trouble. That sudden increase in pressure from the flush can actually worsen ICP and potentially damage delicate brain tissue. Plus, anytime you introduce something into that closed system, you increase the risk of infection. And trust me, you do not want to deal with an infection in the brain. Here's a question that often trips people up. What type of fluid do we want to avoid in patients with increased ICP? The answer, 0.45% normal saline, also known as hypotonic solution. Now you might be thinking, but wait, isn't saline good for hydration? And you'd be right, in most cases. But here's the catch. Hypotonic solutions have a lower concentration of solutes compared to the inside of the cell. This means that when we give a hypotonic solution, it actually causes fluid to shift from the bloodstream, the brain cells. And remember, we're trying to reduce swelling in the brain, not make it worse. So, hypotonic solutions are a big no-no in this situation. Alright, let's talk about the Glasgow Coma Scale, or GCS for short. This is our trusty tool for assessing a patient's level of consciousness. A score of 15 means they're awake and alert, while a score of 3 means they're completely unresponsive. Now, when it comes to increased ICP, a GCS of 8 or less is a huge red flag. It tells us that the brain is in serious trouble and the patient's ability to protect their airway is compromised. In other words, they're at high risk for aspiration or respiratory failure, so what do? We prepare for intubation. Securing that airway is crucial for these patients. Positioning is everything when it comes to managing increased ICP. Think of it like trying to drain a swamp. You want to create a downward flow to get rid of that excess fluid. In this case, the swamp is the brain, and the fluid is the extra blood and cerebrospinal fluid causing the pressure. So what's the best position? We want to elevate the head of the bed to about 30 degrees. This helps to promote venous drainage from the brain without compromising cerebral perfusion. It's all about finding that sweet spot. Alright, remember how we talked about hypertonic saline being a potential treatment for increased ICP? Well, like any powerful tool, it comes with potential complications. One of the big ones is pulmonary edema. Hypertonic saline, while great at pulling fluid out of the brain, can sometimes pull a little much fluid into the bloodstream. This can overload the heart and lungs, leading to fluid buildup in the lungs. So, if you're giving hypertonic saline and your patient starts showing signs of pulmonary edema, shortness of breath, crackles in the lungs, what do? You stop the infusion immediately. Cushing's Triad. All hands on deck. Here's a trio you never want to see in your patients. Cushing's Triad. This ominous sign consists of hypertension, specifically widening pulse pressure, bradycardia, and irregular respirations. It's like the brain is sending out an SOS signal, telling you that things are going downhill fast. Cushing's Triad indicates that the pressure inside the skull is reaching a critical point, and brain herniation is imminent. This is a dire situation that requires immediate intervention. We're talking about calling the code team, getting those medications and interventions in place as soon as possible. Keeping the head neutral. Let's talk about neck position. It might seem like a small detail, but it can make a big difference in managing intracranial pressure. Remember, we're trying to promote good blood flow to and from the brain. Flexing the neck or rotating the head can actually compress those delicate jugular veins, which are responsible for draining blood from the brain. It's like kinking a garden hose, it restricts the flow. So, we want to keep our patient's head in a neutral position, aligned with their spine. Think of it as giving those jugular veins a clear path to do their job. Hypertonic saline to the rescue. Now let's say you're checking your patient's labs and you notice their sodium level is low. We're talking below 135 milliequivalents per liter. This is called hyponatremia, and it can actually worsen cerebral edema. Remember how we talked about fluid shifting from areas of low concentration to high concentration? Well, when the sodium level in the blood is low, it creates a concentration gradient that pulls fluid into the brain cells. To combat this, we can use our friend hypertonic saline. It helps to pull fluid back out of the cells and into the bloodstream, reducing swelling and hopefully improving that sodium level. Altered level of consciousness, the early bird. When it comes to increased ICP, early detection is key, and often the first sign that something is amiss is a change in the patient's level of consciousness. This could be anything from subtle confusion or restlessness to more obvious signs like lethargy or difficulty responding to questions. The tricky thing is that these changes can occur before any noticeable changes in vital signs or posturing. So, it's important to be super observant and trust your gut. If you notice even a slight change in your patient's mental status, don't brush it off. It could be the first clue that something is brewing. Serum osmolality, keeping tabs on fluid balance. Remember our friend mannitol, the osmotic diuretic? Well, when we give mannitol, it doesn't just magically disappear. It affects the body's fluid balance in a big way. One way we keep tabs on this is by monitoring the patient's serum osmolality. Think of osmolality as a measure of how concentrated the particles are in the blood. When we give mannitol, it increases the osmolality of the blood, drawing fluid from other areas like the brain. By monitoring serum osmolality, we can make sure the treatment is working and adjust the dosage as needed to avoid any unwanted side effects. Bradycardia, a late sign. Alright, let's talk about bradycardia. We know that a slow heart rate can be caused by a lot of things, but in the context of increased ICP, it's a late and ominous sign. Remember how increased ICP affects the brain from the top down? Well, as the pressure builds and the brain starts to herniate, it puts pressure on the brainstem. The brainstem is responsible for all those vital functions like breathing and heart rate. So, when we see bradycardia in a patient with increased ICP, it's a sign that the brainstem is being compressed and things are getting very serious. That's a wrap. And there you have it, nurses. We've popped the lid off of 15 challenging ICP practice questions. I hope you found this video helpful and maybe even a little bit fun. Remember, mastering these concepts takes practice, so don't be afraid to re-watch this video, test yourself, and really dive deep into the rationales. Just like with any good extraction, the more you understand the underlying mechanics, the better equipped you'll be to handle any situation that comes your way. Don't forget to like, share, and subscribe for more content like this. Stay curious, stay informed, and keep on popping those nursing exams.